Bismillahirrahmanirrahim. We will start with quote of the day, which is by the Holy Quran. This is the book about which there is no doubt, and guidance for those conscious of Allah. So now we will start with the today's topic, which is primary healthcare governance, policy, and models in Pakistan. I am Dr. Temia Ayub, and I will be presenting this topic under the guidance of Professor Dr. Saira Afzal, Dean Institute of Public Health. Learning objectives. These are the learning objectives of today's lecture. By the end of today's lecture, students will be able to explain the governance of the primary healthcare in Pakistan, describe implication of the 18th Amendment on particularly in context of primary healthcare, differentiate federal, provincial, and district role in maintenance and in service delivery of primary health care, analyze governance challenge at PHC level, describe PHC service delivery models, compare BHU, RHC, and family practice models, explain outreach and mobile services, apply models to Pakistan's context. Primary healthcare governance and policy in Pakistan. So we will start with the governance and policy specific context first. So, what is health governance? Health governance refers to decision making processes, allocation of authority and responsibility, accountability mechanisms, stewardship of health systems. In PHC, governance determines who plans services, who finances services, who delivers and monitors services. Governance level in Pakistani healthcare system. So as you can see, three government tiers are there: federal level, provincial level, and then district or local level. Primary healthcare is primarily governed at provincial and district level, and we will explain the role in detail now. Okay, so this is a very basic summary of the primary healthcare and care governance hierarchy in Pakistan. So, what does federal government do? It is there for policy coordination and regulation. Provinces are there to determine health policy, planning, and financing. Districts are going to manage and supervise all this, and then BHU, RHCs, and outreach are responsible for the particularly for service delivery. This is a very basic summary. So then we have 18th Constitutional Amendment in 2010. Uh, because of that, key change was that health became a provincial subject. Before 18th Amendment, centralized planning and control was there. After 18th Amendment, provinces were responsible for policy, planning, service delivery, and human resources. Impact of devolution on primary healthcare. There were positive effects like context specific planning, greater provincial autonomy, innovation at local context. Then there were challenges like interprovincial variation, capacity gaps, and fragmentation. So now, after post-devolution, what is the federal role in PHC? Federal government retains policy guidance and coordination, international commitments like World Health Organization and SDGs maintenance, national program partially, regulation and standards for all this. For example, national health policies are done by the federal government, drug regulation at national level is done by the federal government, and disease surveillance coordination, like some outbreak of diseases or coordination at national level is done by federal government. Now we come to provincial role in primary healthcare. Provinces are responsible for PHC service delivery, management of BHU and RHCs, recruitment and deployment of staff, budget allocation. Provincial departments, health department are there, and primary and secondary healthcare department, specialized healthcare departments are there in Punjab, and in there are in other provinces they are by other names, or there is only single department for health. Then we come to district health system. District is the operational unit of primary healthcare. Key responsibilities are day-to-day management of BHUs, RHCs, supervision and monitoring, community engagement, and data reporting. And the person who is in charge of everything, or the key administrative authority, is the district health officer. So there are strengths and gaps for district health system. Strengths include that it is proximal to the community, better local understanding of the politics or the social or cultural context. The gaps are that limited financial autonomy is there, weak managerial capacity due to small unit, or political interference is very common, and it can affect the working of day to day at the district level. Okay, so this is a summary diagram for the primary healthcare governance and policy in Pakistan. So we will start with the left side with the summary of 18th Constitutional Amendment in 2010 and how it has affected the provincial autonomy and context specific planning is necessary. Then we have the again federal policy and coordination regulation, province, and then we come to province for health planning and financing. Then districts are involved for management and supervision, and then finally BHU, RHCs, and outreach staff is there for implementation. Federal role, again, the summary is there: governance challenges, fragmented authority, weak district capacity, political interference is there, accountability gaps are there. So, what is the future of primary healthcare in Pakistan? It lies in strengthening district capacity, integrated and equitable primary healthcare, sustained funding, and effective accountability. So, this is a good diagram to show the summary of primary healthcare governance and policy, what we have discussed so far um, right now. So now we come to another important aspect of accountability in primary healthcare governance. Accountability mechanism should be put in place, which include administrative reporting, HMIS system, supervisory visits, and performance indicator. Weak accountability leads to poor primary healthcare performance. So, some of the governance challenges related to primary healthcare in Pakistan are fragmented authority, weak district capacity, political influence, limited community participation, poor coordination between programs. So, this is the summary of the challenges in primary healthcare. Primary healthcare service delivery models. This is another important part of my presentation. So we will be discussing what are the primary healthcare models in particularly with context to Pakistan. So what is service delivery? Primary healthcare service delivery refers to how essential services are organized, where services are provided, and who provides them. The main goal is accessible, continuous, and comprehensive care. So this the what I'm going to discuss in the coming slides are some of the primary healthcare service delivery models with context to uh, global context, and we will see which of them are currently being in place in Pakistan. So number one is fixed facility model. Fixed primary healthcare facilities includes basic health unit, rural health care centers, and these are the backbone of primary healthcare in Pakistan. So this is a very small summary of a basic health unit. It covers 10,000 to 25,000 population. Services include OPD, maternal and neonatal child health services, EPI program, and basic diagnostic. There are outreach staff and also fixed staff posted in a BHU, which includes medical officer, LHVs, dispenser, and support staff. Then we have rural health center, which covers more population than BHU, about 30,000 to 50,000 population. Services are 24 by 7 care, emergency services, minor procedures, referral support. There are compulsory women medical officer and medical officer in a rural health center. So, what are the strengths and limitations of BHU RHC model? Strengths are structured system, geographic coverage. Limitations include staff absenteeism, limited hours, and quality concerns. So, these are some of the issues. On second number, we have family practice or family medicine model. This is particularly in true for some countries like Canada, in which they are universal healthcare more oriented systems. So key features include first contact care, continuity in care, person-centered approach, and gatekeeping role of the actual more tertiary healthcare level facilities. So, family medicine or family practice are going to gatekeep to avoid rush and to avoid congestion at tertiary healthcare or secondary healthcare level. Family practice in Pakistan, current status is that limited formal integration. Mostly, there are small family practice units in urban private sectors. Potential role is that if we strengthen the referral system and reduce, so they can ultimately reduce the hospital overload. So there is much potential, but it is not being currently rightly tapped into. Then we come to outreach services. Outreach services means that services delivered outside fixed facilities. For example, lady health workers, vaccinators, school health visits. Sorry. They are critical for maternal and child health. Mobile health services include mobile clinics, camp-based services, emergency outreach, used for hard-to-reach population, emergencies, and disaster. So, mobile health services are particularly those health services which are in used either in disasters or emergencies to reach the population at far off areas. Integrated primary healthcare service delivery. And so, what is integrated model? Which combines fixed facilities, outreach services, and referral linkages. So, which combines all these. It is the preferred model for primary healthcare strengthening, and it is known as integrated primary healthcare service delivery. So this is a short summary to compare service delivery model in Pakistan. So first we have model, then strength, and then limitation. For BHU RHC, again strength is coverage, limitation is quality gaps. Family practice is the strength is continuity, limitation is limited scale. For outreach staff, the strength is equity and the limitation is sustainability. For mobile, it is excess and the limitation is the costing which comes into maintaining our mobile teams. So recent primary healthcare policy shifts in Pakistan, we are all aware of them. So we will focus on few PHC policy shift under the current regime. Punjab has introduced new primary healthcare service delivery approaches aimed at decongesting tertiary hospitals, improving first contact care, enhancing accessibility in urban and peri-urban areas. These initiatives represent a shift from facility-centric primary healthcare to service-centric primary healthcare. So, evolution of PHC service delivery in Pakistan. Tradition model is about BHUs and RHCs as backbone. Emerging model is about filter clinics, clinic on wheels, outreach heavy service delivery. All these changes indicate adaptive primary health care, but again, it comes with certain risks. So, first of all, we have Mariam Nawaz filter clinics. Filter clinics are first contact outpatient clinic located near or within major hospital designed to screen patients, manage minor ailments, refer only genuine or complicated cases to tertiary care. Policy intent behind these clinic is to reduce OPD burden on teaching hospitals, strengthen gatekeeping, which has been historically being weak in Pakistan. Then we have Clinic on Wheels, mobile primary healthcare units, which are mobile, fully equipped primary healthcare unit. Target is underserved urban slums, remote rural areas, emergency and disaster setting. They have services which include outpatient services, basic diagnostic facilities, and medicines. So this is a diagram or summary figure showing primary healthcare service delivery models in Pakistan. We start with BHU RHC model and their benefits like established network and available 24/7 in cases of rural health centers. Then we have family practice models which are holistic preventive approach, reduce hospital overload with benefits of holistic preventive approach, reduce hospital to ultimately reduced the tertiary healthcare load. Then we have outdoor services which have sustainability issues. Then we have mobile health services which are only basically used in cases of for basic diagnostics and medicine with the OPD services by a doctor. Key consideration and challenges are that human resource constraints, equity and access, referral and continuity of care. Continuity of care is one of the main issues which should be kept in mind while planning the primary healthcare services. And all these models have their own pros and they have their own benefits and harms or cons. So we should keep that in mind, considering our local and cultural context in mind while planning primary healthcare services in Pakistan. And integrated primary healthcare service delivery, which combines fixed outreach and mobile services, this is the optimal for any situation, particularly for Pakistan. So this was the presentation so far. Now we come to multiple choice questions in our presentation. So the first MCQ is, sorry. After the 18th constitutional amendment, which of the following became the prime responsibility of provincial governments in Pakistan? International health commitments, B. Drug regulation, C. Primary healthcare service delivery, D. Global disease surveillance, or E. WHO coordination.
C.
Yes, it is C, primary healthcare service delivery. Which governance level is primarily responsible for day-to-day management and supervision of BHUs and RHCs? Federal government, provincial health department, district health system, tertiary hospital, or local government councils.
Uh, District health system. C.
Yes, yes, it is a district health system. A district health officer identifies frequent staff absenteeism and poor reporting from BHUs. Which governance function is most directly compromised? Policy formulation, regulation, international coordination, management and supervision, and or health financing.
D.
Yes, it is D, management and supervision. Yes, it is right. You are right. Which of the following is a key retained role of federal government in PHC governance after devolution? Recruitment of BHU staff, management of RHCs, policy coordination and regulation, district level monitoring, or service delivery.
C.
Yes, it is C, policy coordination and regulation. Yes. Which features best differentiate rural health centers from basic health units, focuses on preventive services, community outreach activities, 24 by 7 emergencies and referral services, smaller catchment population, or absence of medical officers.
C.
Yes, it is. Usually, RHCs have 24 by 7 emergencies. The family practice model primarily contributes to which health system function? Vertical program implementation, continuity and gatekeeping, emergency preparedness, tertiary care specialization, disease surveillance. It is basically continuity and gatekeeping. Yes, it is continuity of care is important aspect of family medicine practice. A tertiary hospital OPD is overcrowded with patients presenting minor ailments. Which recent primary healthcare intervention in Punjab was specifically designed to address this issue? strengthening BHUs, expanding LHW program, Mariam Nawaz Filter Clinic, contracting a private hospital, or introducing health insurance.
C.
Yes, it is C. Which of the following best describes outreach services in primary healthcare? Hospital-based specialty care, service delivered only through mobile vans, services delivered outside fixed health facilities, emergency-only services, or private sector outpatient services.
B.
Uh, it is basically C, services delivered outside fixed health facilities, outreach services. So it can be through anything, even apart from mobile vans, it can also be done through that. A mobile health unit is deployed to a urban slum following flooding, providing OPD services and essential medicines. This model is best described as fixed facility primary healthcare, family practice model, outreach services, clinic on wheels, mobile primary healthcare services, or tertiary care extension. It is yes, clinic on wheels, D option, yes. Which of the following is the most important limitations of filter clinic and clinic on wheels as primary healthcare reforms? Lack of political support, limited diagnostic capacity, weak continuity of care, absence of trained doctors, or poor patient acceptability. Yes, at this point, it is
D.
weak continuity of care. Because for primary health care, the continuation in care or the that is very important. So for that, so these are some of the questions. See, this is the answer key. This is the YouTube channel where this video will be uploaded, and thank you very much for listening.